Welcome to the Case for International Outreach, a presentation about how helping women, children, and men in the developing world is at the core of Catholic Healthcare's mission. I'm Bruce Compton, Senior Director of International Outreach at the Catholic Health Association. In my role, I work with CHA members and our partners to understand the bigger picture of Catholic Healthcare's ministry in the developing world. This presentation offers the case or rationale for all of this activity. It includes insightful and inspirational comments from leaders in Catholic healthcare who have theological and international outreach expertise. I hope the presentation inspires you and that you will share it with others across your organization. International outreach is a very important part of the mission of the Catholic Health Ministry.
Originally, when people came from Europe to America, religious organizations, they set about providing the needs that they found right in front of them. People were sick and they needed health care. People needed education, so they started schools. Now, this has evolved now into a much bigger world. This is where we get into the global enterprise. We now know there are people who don't have what we have. We now know that we have things that other people can use in third world countries.
I believe it's really important for the Catholic Health Ministry and our organization to be committed to international health, global health. And there are many reasons for that. I would say fundamentally, our mission calls us to serve those most in need. And anyone that's been in a third world country truly knows that that is where the greatest need in the world is. And so having that a part of our ministry is part of Catholic healthcare. It is to really reach out to those most in need.
Our work stems from the ministry of Jesus that has been carried forward throughout the centuries.
Part of our own Catholic tradition is simply that this is not a me and God sort of situation, that the only way I ultimately show the love of God is by what I do for my sister and brother. What's happened over the centuries is that has been expanding and expanding and expanding. The early years of Christianity, still at the time of Paul and James, the apostles are saying how we treat each other is important, love of enemies, caring for those who are the least of our sisters and brothers. As the centuries moved on, especially in the last 100+ years, the popes have been emphatic about this, beginning way back in the 19th century with Leo XIII, but even more so since the Second Vatican Council. Pope Paul VI basically said that our faith has to show itself in how we treat the least of our brothers, not only in our city or our state or even in the United States, but throughout the world. The U.S. bishops have said that the common good is now a planetary common good. And Pope John Paul II has acknowledged that we're really dealing with global solidarity, that we are all, he said, really responsible for all. Finally, Pope Benedict has suggested that while globalization can make us neighbors, our faith has to make us sisters and brothers, and therefore we have to see ourselves as brother and sister to everyone in the world. And that demands certain responsibilities on all of us who claim that we're Christian. How we treat those poor, not only in our midst, but everywhere, is how we show that we are truly daughters and sons of God.
As Father Tom notes, the call for solidarity in international outreach emerges from the notion of the human race being a single family, and whenever there is suffering and need, it is a demonstration of faith to offer compassion and aid. Pope Benedict reminded all who work in charitable organizations that human beings always need something more than technical proper care. They need humanity. They need heartfelt concern. Those who work for the Church's charitable organizations must be distinguished by the fact that they do not merely meet the needs of the moment, but they dedicate themselves to others with heartfelt concern, enabling them to experience the richness of their humanity. Thus, the activities we undertake to share resources with the developing world, as well as the spirit in which we conduct this work, is a twofold expression of our commitment to participate in the human family and provide health and hope to all.
What's important about Catholic healthcare organizations is that they're able to not only provide some support in terms of healthcare, sometimes they're the only ones providing healthcare in some remote locations, but they also bring compassion and wholeness to the person. And that's a very important part of health. It's not only treating a patient, but it's bringing the patient back to wholeness.
Along with providing services with compassion, our commitment to justice calls us to this work. While a seemingly insurmountable reality, our activities can help decrease the vast inequalities in global health outcomes and the burden of disease. In 2000, the Global Forum for Health Research provided data demonstrating that less than 10% of global spending on health research is devoted to disease or conditions that account for 90% of the global disease burden. This is often referred to as the 1090 gap. The Global Forum estimates that deadly diseases such as pneumonia, diarrhea, tuberculosis, and malaria receive less than 1% of total private research dollars, although they account for more than 20% of the global disease burden. As we work towards ending injustices in care and access, the how is very important. Regardless of where a person is served, in the United States or in their homeland, all persons and their families need to be treated holistically, with respect and attention to body, mind, and spirit. This is part of Catholic healthcare's identity and tradition. Having the capacity to function effectively as an individual and organization within the context of cultural beliefs, behaviors, and needs presented by the community is a critical aspect of international outreach. It is essential to consider the community's language, culture, historical, economic, and political background as we work in this important area.
Almost every African culture has the saying, "I am because we are." When I talk to students in Africa about autonomy, for example, they're shocked. When I speak autonomy, they hear abandonment. When I talk about individualism, they hear being without your community. For them, the only way to live is to live in community. I think one of the biggest examples for me was a woman who was a housekeeper for the Franciscans. It was Christmas time, and the Franciscans wanted to give her a gift. She was very easy in answering, "I wanted 50 pounds of flour, 50 pounds of sugar for my village." Good, but now what do you want? Well, I want 50 pounds of sugar, 50 pounds of flour for the people in my village. Fine, we'll do that, but what about for you? I want 50 pounds of flour and 50 pounds of sugar for the people in my village. She could not at all distinguish what she wanted and the needs of her village. That is so different from our culture. And it taught me an awful lot of lessons regarding what solidarity means, what being part of a community means, and how much our culture has really affected and has been infected by individualism.
To really make sure that we listen to the communities we're serving, to what they have identified as their needs, and really do our very best effort, make our very best effort to not bring in services, supplies, medications that are not appropriate, not needed.
We want them to know that part of our mission of going to these different countries is that we work in partnership with the people there. So it's not like we come there and take over their program. No, we work in partnership with the people in each country.
A long time ago, I read an article that said the greatest language that we have is to share a gentle touch and a smile. And just by greeting each person, looking them in the eye, and whatever their language is, everyone can say hello in someone else's language. And a gentle touch on the shoulder and greeting that person just says, "I'm here to meet you. I respect you. And that is what we try to promote among all of our team members.
Kleinman and Benson, professors at Harvard University, offer a case scenario demonstrating how assumptions, which appear to be culturally competent, hinder a practical understanding of a subject's needs. It can prove an important example of why we cannot fulfill our mission of alleviating suffering if we pack our assumptions about the third world along with our clothes when we participate in mission programs. In the scenario, an HIV-positive Mexican man, whose wife died of AIDS a year earlier, is asked why he has not taken his 4-year-old son, who is also HIV-positive, to regular doctor visits. Clinicians assumed the man held substantially different beliefs about the nature of the disease. However, upon inquiry, clinicians found the man had a near complete understanding of HIV/AIDS and simply had not followed up on regular visits because he worked long shifts as a bus driver. His failure to attend was not because of cultural differences, but rather his practical socioeconomic situation. Talking to him and taking into account his local world was more useful than assuming radically different health beliefs. It's not only cultural differences that matter. We need to understand the realities on the ground in the communities we are partnering to serve. Routine things here in the United States may be inappropriate elsewhere.
Some major differences between healthcare in the U.S. and some in developing countries is that the U.S., the manufacturers of medical equipment, base a lot of their revenue on the consumables. So it's a single-use, disposable kind of model where you use a piece of tubing once, use it on one patient, and then you toss it and use a new one for the next patient. In developing countries, that may be very cost prohibitive. So they tend to take those single-use devices and reuse them over and over and over again because they cannot afford to use a piece of tubing, a new piece of tubing for every patient. So that's just kind of one example where our disposable single-use model here doesn't really sometimes fit the economic realities of many countries.
In Peru, there was a young man that was paralyzed, and the whole community chips in monthly for his medical supplies so that he doesn't have to reuse the same catheter. And you just say, you mean the whole village of Pacaypampa does this? Yes, so that he has a clean one every day. You get moved by the simplicity of the people and how they've come to help each other. And you want to come back and say, oh, I wish our communities would do that in the United States.
In addition to cultural competence, operational competence must be a part of our ministry's response to global need, and quality is a key component.
If we think about the Sermon on the Mount in Matthew's Gospel, there's an interesting way in which Jesus presents almsgiving, prayer, and good works. In every case, we're supposed to do it in secret. And Jesus, who sees in secret, will reward us. And, well, what we do in healthcare isn't a secret, but it's often a secret from the person who receives the care because it's done behind the scenes. And I think, in a sense, we can take that message to heart. We don't maintain excellence or high quality because we want to be seen, but because we understand that in doing this, we're extending the ministry of Jesus.
There should be no difference in healthcare, regardless of where it's provided. I think, in essence, it's really a matter of justice. God has provided us with the skills and the minds that we need to realize marvelous advances in medicine. And I really think those advances belong to all His people. If we begin to make differentiation in the quality of care, we set up a precedent that has far-reaching impact.
Overall, this work matters. It matters to the families and communities who are able to access health care because of our international outreach, and it makes a difference in the lives of those who participate in this work.
I think inside of each person there's a gnawing feeling that there's something else I can do. And many of them, when they see this opportunity, it's like a light goes on and they say, this is it. This is what I need to do to be more of the person that I am. And so we have that opportunity to invite people to share this ministry. And it's not just by going on the mission trips with us. We have volunteers who work for us in their own home and help to provide the supports that are necessary. We have volunteers who come to our office and give an hour or two, students who come. And there is something about the sense of being a partner in something bigger than yourself. And that is what many, many people are seeking.
Our mission to be a healing and transforming presence in the communities we serve is so important to us, but it's also mostly a mission in the eastern United States. So when we go out to international markets, to developing countries, it's really a transformative time for our volunteers. Our doctors, our nurses, our staff that go out to Peru or Guatemala, Jamaica or Haiti, what they see there is a whole different world. And they come back here changed individuals. It's transformative. They come back here and what they see in the challenging times of decreased reimbursement and every day saying, how are we going to make it? They say, we have abundance. We can use that abundance to continue our mission to take care of the poor here in the United States. It's a life-changing experience for our volunteers, for our colleagues.
I have lived in Belize, and I grew up in the inner city of New York and the Bronx, and I've seen different levels of poverty. But being on a mission trip has opened even my own eyes to the simplicity of the people in each country that's a little different, and the importance of just being able to be with the people. And that no matter what we bring, and no matter how we come into the country, or no matter what we provide them with, the thing that I think stays with me is that they know somebody cares enough to come to their village, somebody cares enough to come to their country to provide them with the minimal basic health needs, and that they're willing even to just sit with them in their pain and in their suffering and listen to them. And if anything, that I think is probably the most important thing, to let people know that they're cared for, and we do that.
Thank you to all the leaders who have shared their expertise and insights. So that you can further explore our call to international outreach, here are some resources you can easily access. Feel free to contact me as you undertake international outreach activities. This is an important part of our mission, and together as a ministry, we can make even greater strides to increase access to the most basic care and to help bring about a more just world.